The wait is over. The day has come. That's right. Just yesterday, CMMI released their brand new ACO model called LEAD, Long-Term Enhanced ACO Design Model. This is a long time coming. We've been waiting for this announcement. Once we knew the ACO REACH was going to be sunset after performance year 2026, we didn't know if there would be an extension or maybe a brand new model, a total cost of care model that would replace ACO REACH. But thankfully, this is pretty similar to ACO REACH. Some are calling it ACO REACH 2.0 or even global contracting 3.0. There are some very distinct differences. I'm going to walk through those with you. I'm going to give you the top five similarities between ACO REACH and LEAD, and the top five differences between ACO REACH and LEAD, just so you know what's going on. So let's jump into it. So this brand new program under CMS's innovation arm, CMMI, will replace ACO REACH starting January 1st, 2027. You'll get a chance to apply this March, and there'll be brand new applicants. So if you remember with ACO REACH, only the entities that were approved early on were the ones allowed to be able to continue to be a part of the program. Obviously, now those ACO REACH entities can move into LEAD, or now new ACOs or other ACOs, whatever that means. I assume MSSP can move into LEAD. Providers that are still in fee-for-service can move into LEAD. And then one that they're definitely targeting is federally qualified health centers and rural health clinics. So let's get into, there's still a lot to be announced for sure, but let's get into the top five similarities between ACO REACH and LEAD. For one, this is a voluntary two-sided risk ACO model for traditional Medicare. So no Medicare Advantage. This is the total cost of care plus quality, very similar to ACO REACH. Not a lot of differences there. There are some risk options, very similar, both professional at 50% and global at 100%. In the past, if you heard of an ACO REACH, most likely they were global, unless they announced that they were professional. This is the high risk, high reward. This is all really kind of the premium ACO model out there. So those still stay intact. There's some population-based and capitated payment structures. They didn't get into too much detail, but with ACO REACH, there was options at full capitation and just the primary care capitation. Both big deals. If you think about whether it was a health system, a practice, a community health center, having a steady flow of funds is a big deal. You can do a lot with those. You can say, hey, I know that I'm getting $1,000 per Medicare beneficiary per month, so I can invest in telemedicine, or I can buy a mobile unit, or I can invest in data and technology, and just know that I can reach out to patients as much as I want to, engage with them however I want to, provide transportation. You could do a lot of things with that revenue instead of thinking about things as fee-for-service, volume. Huge deal. Glad this is intact. A lot of people from MSSP were asking for this. Instead, they got PC Flex, which was not necessarily the best program. But this is a great way to do it. So glad that that's intact. Another big deal. A lot of people will be really, really happy about this who have been in MSSP for a long period of time. And this is a static benchmark for predictability. So if you remember with ACO REACH, those static benchmark years were 2017, 2018, and 2019. And the benchmark never changed. You didn't have to worry about rebasing. You didn't have to worry about ratcheting effect. You just knew what your benchmark was, and you knew that you were focusing on that. And the fact that this is such a long program, that's a big deal. So for those groups that had to, as they were performing well, had to compete against themselves again and again, it makes things really, really tough. It's probably the number one complaint against MSSP is, hey, I'm having to outperform myself year over year. This isn't fair. I'm doing better than my peers. Why am I not getting those shared savings? So huge deal for those top performers as well. There are some use of benefit enhancements and beneficiary incentives. This was kind of a more of a quiet part of ACO REACH, but there were some great opportunities to be able to provide these enhancements and incentives to patients. The most common one I saw were groups covering the copay for programs like chronic care management, where a patient didn't want to pay $8 to $10 for that chronic care management engagement every single month. So the ACO said, I know this is going to lower the total cost of care. Let me cover it, and so they could use that waiver. A big deal there. LEAD actually does introduce, in addition to some of those, some brand new ones. I think most people are pretty excited about this new Part D premium reduction. So those medications can be covered by the ACO. Still a lot of details to come out about that, but I think there's a lot of excitement. All right, now let's get to the good part. The top five differences between ACO REACH and LEAD. For one, the model duration. So ACO REACH was just a very short 4-year program versus LEAD is a whopping 10-year program. That's right, 2027 to 2036. I don't even want to think about how old I'll be at that point. Maybe I'll age into Medicare. But it's a long program. And the goal is that they're trying to get groups to think about things long term. I even know at working for an ACO REACH entity for 3 years, there were groups saying, hey, there's only 3 more years of this. There's only 2 more years of this. I don't need to get excited about this. I want to know what's coming next. So knowing this is in place for 10 years, this is CMS putting a bet on value-based care and knowing that we'll be on the right side of history when it comes out of 2036. I'm really excited about this. This is a big, big deal. Second, there's a lot of focus on high needs across all ACOs. So under ACO REACH, there was a designation, a specific high needs ACO REACH. That's gone away with. Now all ACOs under LEAD will be focused on high needs and those very unique patients. It's different. I don't know if a lot of people are excited about that, but it's definitely different. It'll take some adjusting. One big one that I am excited about, especially as being understanding that value-based care is all of healthcare, is this new CARA. Maybe Sarah, I don't know about the pronunciation, but it looks like CARA, CMS administered risk adjustments. So these are episode-based risk arrangements with preferred providers. So these preferred providers, think about them as like specialists, meaning that if you're going to have a surgery, you're going to have, maybe an orthopedic put together that surgery plan, a PT put together that the physical therapy, and you have, everything that's, and then the hospital cost, all of it kind of wrapped into an episode based. That's using one example, but this is a big deal for those specialists who have been asking about value-based care. I speak about value-based care a lot, and I always have specialists saying, how do we get involved? I'm a nephrologist. I'm a cardiologist. How do we get involved in this? We understand that there's, we're reaching capacity needs too. How do we get involved? And this is a great way to do that. Still new. Again, this is one of those brand new things where as CMMI, each program, they learn from something and they say, yeah, let's make a tweak here, or let's introduce something brand new. This is exciting. They've been giving us the data for the last couple of years, but this is a major shift. Another big one is looking to target new, small, rural, and independent providers. One of the ways that they're doing this is by lowering the beneficiary alignment, minimums. So before those were 5,000 lives, or you couldn't be a part of it. You'd have to join somebody else, and so you'd get above that threshold. Most groups were looking at 6,000 lives just to not cut it close because there was no mercy rule. But this allows that hurdle to be able to be much more easy to be able to participate, which is what they want. If you remember, they came out with Making Care Primary and a lot of other models that really focused on smaller groups. I think CMS and CMMI realized these are the hardest ones to get involved in value-based care. But it's a big initiative from CMS and CMMI across the board. So if you're not familiar with the Rural Health Transformation Fund, this is a big deal. It's a big part of Arcadia too, is this $50 billion fund that's going across state to state, 50 different states getting this $50 billion, and being able to really help rural groups be able to have the right infrastructure, the right data, the right technology. Happy to talk about that another time. Let me know if you'd like to hear more about it. But rural and smaller groups and FQHCs and all these groups are a big deal for CMMI. Which leads us to the last difference number 5, the incorporation of providers serving Medicaid patients, these dual eligible patients. In fact, they specifically named that they're going to be including this and focusing on 2 states specifically, and with the goal that those 2 states will eventually become and have their own Medicaid ACOs that are involved there. So really unique to see how they tie that. Obviously, Medicaid's different, and you have a state by state versus run on a federal level. So it'll be really unique to see how that turns out. Well, that concludes the top 5 differences, top 5 similarities between ACO REACH and LEAD. I'd love to know from you, was this helpful? What topic would you like to hear more about? I really would like to do more of these in 2026. So let me know what kind of topic you'd like to hear about. Also, you can send me an email at michael.dudley@arcadia.io. You can go to my YouTube where I just post all of these videos, so you have one easy way to look at it. Value-based Michael. And then, of course, feel free to take a look at Arcadia. Arcadia is doing a lot, especially after our acquisition of Care Journey, to really bring as much data and technology, analytics, AI to your fingertips, so that you can be able to align with the right providers, find the right patients to attribute to your ACO, and really be able to increase performance as time goes on. So with that, thank you so much for watching. Hopefully this is helpful. Let me know. And until next time, I'll see you later.